All right, I'd like to introduce our next speaker today, Dr. Carol Fenton. She's the Medical Health Officer in Interior Health, and she's going to provide an overview on the opioid crisis.
Hello, good morning. Hopefully, it won't be too much of a repetition. Dr. Montana managed to fit an incredible amount of information in his opening remark. Thank you. Hold on, let me just load up my situation and find the share button. Here we go. Can everybody see that?
Yes, we can see it.
Perfect. Okay. All right. So thank you everybody for having me at this meeting. It's a new group, so I'm happy to meet you all. And it's very important work that you do as outlined by Corrine and Dr. Montana. So thank you. And I apologize if the presentation isn't exactly what you want. If you provide me feedback, I'll improve for next time. So I do want to start with a land acknowledgement. I did come late, but I caught the tail end of the elder welcome by Sheila. Thank you so much for doing that for the group. And I just want to say that from the interior health perspective, we recognize and acknowledge that we are collectively gathered on the traditional, ancestral, and unceded territories of the 7 interior region First Nations. I'm calling in today from Secwepemc territory that's also known as Kamloops. And then this region, which is the whole IHA region that I'm referring to, is also home to 15 chartered Métis communities. It is with humility that we continue to strengthen our relationships with First Nations, Métis, and Inuit peoples across the interior. So I'm very grateful to be here and working here. So I was asked to just give an overall update of the toxic drug poisoning crisis, and I saw the last update that was given by Dr. Mark Lesishin in 2020, so I tried to base my slides off of that. So the graph we have here is the illicit drug toxicity deaths, which are the bars of the bar graph, and then the death rate per 100,000 population, which are the lines that goes across the top of the bar graph. Along the bottom here, I apologize, it's a little bit small and hard to read, but we have the years from 1996 to 2022. Beneath that, we have the absolute number of deaths as well as the rate. So just looking at it overall, we see that the deaths and the death rate were somewhat stable and well below 500 until 2015. In 2016, you see a sharp increase, and that was the year that the public health emergency that was declared. We continued to see an increase to 2017, and then a leveling off in 2018 and a decrease in 2019. But unfortunately, all of that progress was lost, which coincided with the timing of the COVID-19 pandemic. And so 2020 and 2021 were progressively the worst years that we have ever seen. And then 2022, this data is only as of March 31st. And so the bar is not useful because again, it's only for the first 3 months, but the rate hints that we may be turning the corner. But again, time will tell because we have the rest of the year. And I know that there have been some months since this graph was made. And so I know that the toxic drug activity has been quite busy in my geography. And so putting that into context with other causes of unnatural deaths in BC, you see the solid, I think it's a very dark navy line, which is the same pattern that we just described on the previous graph of our flattening until about 2014, the increase to 2018, that decrease, that success that we saw, and then that reversal of success since then. We can compare that to the small dot line below that is the suicide rate. The small dash in the middle is motor vehicle incidents, and the I guess the dot and dash line is a homicide, and then the light, it's a blue-gray line at the bottom are prescription drug deaths. And so as you can see, since I'd say the end of 2015, toxic drug deaths have been largely, far and away, the major cause of unnatural death in BC compared to these others. This is, again, that same pattern, but we've differentiated it out by health authority. And so what you can see is basically all health authorities are seeing this same pattern with slight variations. At the end, at 2022, you can see Northern, which is a green line, is on top. And then below that is Vancouver Coastal, Interior is next, and then Fraser and Island are currently at the bottom. But if you look back over the graph, there has been some crisscrossing. So it does change, but by and large, you can see that all of the health authorities have followed the same pattern. And so looking across the province, this is data from the BC Coroner Service Death Review Panel with data from January to October 2021, so only a short interval of time. But as you can see, there is geographic variation in the death rate by health service delivery area. So what we have here is the darkest red is a rate of over 50 per 100,000 population, with progressively lighter shades up to yellow. I don't think there is a lightest yellow area on the map. So the areas with the least rate fall between 10 and 20 per 100,000. And so as you can see here, the Northwest and the Thompson Caribou Shuswap, as well as urban Vancouver, are the most affected for that period of January to October 2021, with others such as Richmond being slightly less affected. But by and large, there is no area of the province that is unaffected by this crisis. And so if we look across at the data that we have and we ask ourselves who is being affected, there are some generalizations that we can make, but basically anyone who uses street drugs at this point is at risk. But in terms of who is dying, we've seen that 74% fall between the ages of 30 to 59, 78% of them are male, 14% are First Nations, which is much larger than the population frequency of Indigenous peoples, and 12% have been homeless. In terms of where the deaths occur or where people are found having died from toxic drugs, 86% of those occur inside. Within that, 56% have been found at a private residence and 29% at other, and other is generally like a group home or a shelter type housing, and only 13% of those have occurred outside. 35% of those who have died from toxic drugs have been employed, with over half of those in trades, transport, or equipment operator type employment, and less than half, or 44%, have been on social assistance. And so usually when I'm presenting this data, I ask people to really interrogate the assumptions that they have around who is using drugs and who is at risk. A lot of stereotypes are not supported by this data. We don't see, again, most of these are occurring in private residencies. So this is not, things happening in alleyways. This is not overwhelmingly a problem for homeless people, et cetera, et cetera. So really important that this is generally young males, disproportionately represented First Nations, and a good number of those are employed. And so we need to be mindful of that when we are designing our interventions and making our services accessible. Okay, switching gears a little bit to talk about what's happening with the street drug supply. So these are drug checking results from the BC-CfE, and what we have here, And this is just for the month of April of 2022, so it's a snapshot. We have the number of samples on the y-axis. And so, and then that's charted across the fentanyl concentration across the x-axis. So what we are seeing, and then we have two shades of blue. The darker shade are those that are negative for benzodiazepine contamination, and the lighter shade are those that contained both fentanyl and benzodiazepines, which are a different type of sedative from opioids. So what we see here is that most of the samples have 25% or less fentanyl concentration, with the highest frequency between 10 and 15%, which is really high for the amount of fentanyl. We're seeing about 50-50 of the samples that have benzodiazepines in them, but a really it's striking that we are seeing fentanyl concentrations across the board as high as 75%. Like, that's really dangerous. It's really toxic, and the street drug supply is really unpredictable, and so it's dangerous, as we all know, which is why we are here. And so again, the percentage of opioids testing positive for benzodiazepines in the past 6 months. So again, the last one was just a 1-month snapshot. If we look back over 6 months, we are seeing about 35% consistently across the board testing positive for benzodiazepines. And again, that's that other type of sedative that is not reversed by naloxone. If we zoom out and we look at other types of drugs, so on the left here, we have our opioid samples, and we see that 86% of those are positive for fentanyl. And again, that range of fentanyl contained in that sample can be anything from 5 to 75%, which is what makes it really dangerous. And then if we look across, we've got other types of drugs. And so we've got stimulant samples, and so that would be our methamphetamines and our cocaines. And about 2% of those were positive for fentanyl. We've got our depressant samples, so they would be non-opioid depressants. So they would possibly be people who are seeking benzodiazepines or other sedatives. And 8% of those were positive for fentanyl. In this data, they did not see any fentanyl contamination of psychedelics. They had unknown samples, so unlabeled, and 30% of those were fentanyl positive. And again, since this is a street drug supply, there are no labeling requirements, there are no ingredients, there is no purity of manufacture, and people really don't know what they're getting necessarily, which again makes it really dangerous. So as I'm sure you all know, and Dr. Montana mentioned, in March, we had the BC Coroner Service Death Review Panel report was released. And they did a review of the illicit drug toxicity deaths, particularly the ones that occurred since the declaration of the pandemic, and really gave some urgency behind some of the response. And we are starting to see the response is coming together. It's always slower than we would like, but the provincial meetings are occurring. We have representatives from the health authority at those provincial meetings. And so everyone working on the toxic drug crisis from within the health authority is highly anticipating some of those actions. But in general, the recommendations fall within 3 areas. The first is safer drug supply, because again, the risk of the toxic street drugs is what is driving all of these deaths, and they're entirely preventable. And so that's the first one. The second is a coordinated, goal-driven provincial strategy, which is why we really need the province to lead this work. And it's really difficult to be trying to do it within the health authority alone. So that's why we're waiting with bated breath to see what comes from those meetings. And then the third is the comprehensive continuum of substance use care. So opioid agonist therapy is one of, if not the most important component, but there are so many other elements and pieces of substance use care along the continuum or the spectrum, all the way from safe supply, harm reduction, supervised consumption, to the opposite end of the spectrum, which is sort of detox and residential treatment. And we need anyone anywhere in BC to be able to access any of the services along the continuum and move along the continuum according to their needs in order to achieve the healthiest state possible for themselves. So since I have you as a captive audience, I wanted to talk about prevention, and I'm going to use an analogy, and I hope I don't give it too much of a workout, but I wanted to talk about prevention and moving upstream. So often in public health, we use the analogy of upstream intervention, and the original analogy was, emergency services are generally finding people who are drowned or fishing people out of the water that are in the process of drowning, and then the saying is, well, why can't we prevent them from falling in the river upstream? So why don't we look upstream and see what's happening? So I wanted to apply this analogy to all of the levels of intervention that are available to us from a population health approach, so that we can keep those in mind and understand like the full continuum of actions available to us from a public health perspective. So I'm going to start all the way downstream and then move upstream from there. So when we talk about prevention, the very last step is preventing death once overdose has already occurred. So we do that through supervised consumption, and this can occur anywhere in community. It can be in housing, social housing, subsidized housing. We do episodic overdose prevention services in healthcare settings. We need it for all drug ingestion, injection, snorting, smoking. We do see a transition in the data that most of the deaths occurring now are through smoking, and we don't have facilities for that in most of our supervised consumption site, which is a real there. And these lives are saved through naloxone, so we can actually equip the population with naloxone training and naloxone kits, so that you don't necessarily need a official formal supervised consumption site to save those lives. So again, this is our last intervention to stop people from dying. And naloxone works great if it's given properly, if it's given in time shortly after someone overdoses and their brain hasn't been deprived of oxygen for very long. But if there is a delay for whatever reason, if we need to wait for emergency services to arrive, or if CPR wasn't given while we waited, etc., people can sustain brain damage from being deprived of oxygen when their breathing centers stop working because of an overdose. And so there is a lot of harm here that is avoided in supervised consumption. But again, this is our last ditch effort to prevent people from dying. So this is the mouth of the river into the ocean. So I've provided a photo there. So moving a little bit upstream, how do we prevent those overdoses? Well, one way is through drug checking, so that people know, when they bring in their substance, what are they taking? And if they know, if they have access to a spectrometry or an FTIR machine, we can actually tell them what percentage of fentanyl, so they can actually attempt to dose themselves correctly. Or if we just have the fentanyl test strips, they can know that there's fentanyl and or benzodiazepines in the sample, and then they can use that information to perhaps do a smaller dose, do a test dose before they proceed to taking more. They can titrate themselves that way. And then safe or safer supply, depending on how you like to call it, is a way to avoid the street drug supply entirely. Unfortunately, we don't really have a safe supply a model across the board. We have a few pilots. We have the medical prescribing that was put in place, but there are definitely limitations to that, which is why the coroner's death review panel report recommends really strongly. And so there's two models: the medical model, where each person has a prescription from a doctor that they fill at the pharmacy. And so that is the one that has the most development across the province. But it definitely has limitations because, as everyone knows, we don't have enough doctors to go across the population as it is in BC. So we don't have a lot of extra doctor capacity to take this on. And the other thing is a lot of people who use drugs don't necessarily want their doctor to know about it. They don't want their pharmacy to know about it. They don't want it on their health record necessarily. So, people are definitely reluctant to go this way unless they have sort of an established use pattern, and they're not trying to conceal that from their community. And then there's the non-medical model. So this is more the way we've gone as a society with alcohol, with cannabis, with other substances. And one of the models that is that is evidence-based is a compassion club model. So that's what the Drug User Liberation Front is doing in Vancouver, which they're currently technically doing illegally, but they are in the process of applying for exemptions to Health Canada. And the BC-CSU has a wonderful evidence-based report on compassion clubs. And so I think it's a very compelling model, and I'm hoping that we'll get some more traction for that in the coming months. Okay, and then moving a little bit further upstream, another way to decrease street drug use is to provide treatment. So, if we look at some of the reasons that people take drugs, is to self-medicate. Often mental health conditions that are undertreated, chronic pain that is undertreated, and then of course addiction or substance use disorders. And so if we can treat those conditions appropriately, then people won't need to self-medicate with a toxic street drug supply. And as I mentioned, we need the full continuum of care because often people aren't necessarily ready for whatever service, and so we need to be able to offer them a little bit, and if that meets their needs and they build connections and they feel more comfortable, they can move along that continuum. Or if things happen in their life and they become unstable, they can move back and forth along that continuum. But again, the idea is to keep them connected to care, keep their needs met, and hopefully keep them away from the street drug supply as much as possible. And then moving further upstream, we need to address why people use drugs beyond self-medicating. So providing healthy coping outlets such as natural high alternatives. There's excellent evidence for this in Northern Europe, where they've provided funding and access to sports, music, dance, and art programs for youth that has drastically decreased youth experimentation and youth substance use. Mental health support is really important so that people have, when something happens in their lives, they can cope with that. Building community connections through clubs and events and communities, and equipping people with healthy coping skills so that they have multiple coping outlets and opportunities for themselves rather than being limited to substance use to cope. With safe supply and other things, they can have a combination, or if they have enough of other coping skills, they may not need to use substances at all. And one of the programs that we have for developing healthy coping skills specifically for youth is called Preventure, and we are actively working on rolling that out to high schools currently in the interior. So very excited for that. And then if we go the farthest upstream, you could see here we have a bridge, so hoping that people don't fall into the water at all. And so it's what I would call primordial prevention, so preventing the risk conditions. And so we're talking about the determinants of health. So what determines, what people's life course is going to look like, what their challenges and life challenges or health challenges are going to be in life. And a lot of these things are have mountains and mountains of evidence for them, but they're very difficult especially for groups like ourselves at this table to address, because they are society-wide and generally sort of government intervention level things rather than health authority and health system. And so those things include poverty and income distribution, social safety net, housing, and that's both access to housing and quality of housing, food security, discrimination, and the flip side of discrimination, which is social inclusion. So racism, colonialism, ableism, sexism, these are the things that traumatize people and make them need to rely on those coping behaviors. If we don't traumatize them, they don't need to cope as much. And then the things that help people thrive in our society, things like education, access to education, affordability, appropriate programs, geographic access, job security, working conditions so that people don't get injured at work, or both in terms of traumatic injury and repetitive use injuries, emotional injuries, access to good health services, appropriate health services, local health services, and then early childhood is there because the early childhood is a particularly sensitive time for trauma and healthy development. So it's really, really important. And so that's all I have for today. I hope you enjoyed my public health analogy and I didn't give it too much of a workout. And that's my puppy Chino, and that's the face he makes when he wants something. So I want your questions, please, and thank you.
Thank you so much, Dr. Fenton. We do have a few minutes for questions. If anyone has any, feel free to unmute or type it in the chat. Cole?
I'll give others a chance first, but just want to make a few comments. But anybody else questions first? I don't want to, I'm speaking later anyway, so I want to give other people a chance. All right, well, others are processing all that great information. I just wanted to mention I have a book I think you would like. It's called Upstream. So it has many great examples of what you're talking about. And I like how you mapped out all the possible touch points of intervention for our teams. And so the way we can think of this is that some of our teams have more leverage at different points in that kind of linear way you map that out. So part of what we'll be doing later is figuring out what are those leverage points for our team, where can we have the most impact, and where do we have the most control as our particular team in this collaborative, and then developing our aim statements and our action plan around that. And I was also thinking about how you can map those out on the driver diagram that we'll talk about later today. Just again, it's a slightly different way of visualizing where the leverage points are, how we can improve here. So thanks, I really, that fit well with what we're going to do later.
Wonderful, thank you. And yes, I am very familiar with that book. So I see you've put the link in the chat if anybody else is interested.
Thank you. Cynthia, I see your hand is up. Oh, it's a bit hard to hear you. I don't know if you can come maybe a bit closer to where the microphone is.
We were just wondering if we could get some more information about the prevention program for students, if that's going to be part of what we'll hear more about through this. That's super interesting to us here. We're just starting off an intensive case management program for youth, so we need to hear more about that.
So that was a little bit difficult to hear. There was quite a lot of feedback, but what I gathered is that you want to hear more about the intervention for students, and not sure if you want to hear about the one prevention for youth, or if there are other interventions.
Perhaps you can type it in the chat, Cynthia, if you've got the keyboard there.
I also noticed maybe some people behind you, Cynthia, have their individual laptops as well. I've been on a hybrid meeting recently where not only do you have the entire group join the Zoom meeting, but the individuals on the computer join the meeting too. So then as long as they're muted and have their sound off, it works great, and we can see people better, and sometimes it just works more smoothly.
Okay, so if you wanted to know more about Preventure, I've put the link in the chat.